A 69-year-old male patient who presented with severe headache for past 2 days. He came to the ER department with these complaints, and he was evaluated with CT brain scan, which revealed SAH in the intrahemispheric area, anterior intrahemispheric area. And so he was taken for CT angiogram, which revealed an ACOM aneurysm, which is arising from the um, left A1 segment and ACOM junction, and it was pointing inferiorly and posteriorly. Though the aneurysm is arising from left A1 and A1 is dominant, left side A1 is dominant, the projection of the aneurysm is very difficult from the left side. So we planned for a right pterional craniotomy and right side approach of aneurysm. As the on angiogram images, 3D imaging, we could see the neck of the aneurysm is very near when approached through the right pterional approach. So we proceeded with the right pterional approach, and we started dissecting out the aneurysm. Once the craniotomy is done, we entered the brain and we have retracted the frontal lobe, and we identified the olfactory nerve and followed it, and we could trace out the optic nerve. After later we opened the lamina terminalis and let out the CSF. Once the CSF is let out, the brain has collapsed. Tracing out the optic nerve, the cisterns were opened between interoptic cistern and opticocarotid cistern were opened. Later, tailored Sylvian fissure dissection was done, and the A1 um, ICA and ICA bifurcation was identified. A tailored Sylvian fissure dissection is done, and the branching of ICA, that is ACA and into ACA and MCA, is identified. Now we started dissecting out the ICA and skeletonizing the ICA, and we are following the ACA branch, ACA division of the ICA, and we are slowly reaching the base of the frontal lobe, where we can see the gyrus rectus, and the gyrus rectus is slowly sucked off partially, and we can clearly see the A1 segment of right ACA. Here we are sucking out the gyrus rectus on the right side, and the arachnoid over it is slowly coagulated and cut. After partially removing the gyrus rectus, we could see the A1 segment that is converting into A2, and it is going beneath the frontal lobe. See, we can see the A2 part of right side A2. The recurrent artery of Hubner can also be seen arising from the ACA. The aneurysm bleed, which has formed a clot around the junction, can be clearly seen here. So once the clot is once we can identify the clot, that means we are very close to the aneurysm complex. So we again started skeletonizing the right side A1 segment, so we can get a good proximal control, and we also have to dissect out the A1 on the opposite side, as the left A1 is dominant. Proximal control over the left A1 is very important. So we are identifying the A1 on both sides. Mostly, we are preparing out for the left side A1 segment. Now we can see the full course of A1 segment on the right side up to ACOM junction, every adhesion between the A1 and the optic nerve and the surrounding brain is being separated. Now we can see the first glimpse of A2 on the right side. The first glimpse of A2 on the right side is identified, and we can trace out the A2, and it is going beneath the frontal lobe. The first glimpse of aneurysm complex is visible now, and now we are tracing out the ACOM. That is the ACOM we are moving over, and that is the recurrent artery of Hubner that is going back. So the ACOM is slowly traced. Now we can see the ACOM junction, and the opposite side A2 is visible now. That is the aneurysm complex here visible now. That is the opposite side A1. We can see the opposite side A1, and near the junction of opposite side A1 with ACOM, we can see the ACOM aneurysm that is projecting out. Since we have mobilized the A2 on the ipsilateral A2, now we can directly see the neck of the aneurysm. Aneurysm clip is being applied, and it has been done. Permanent clip has been applied as here in the neck, and now we are further dissecting out the aneurysm complex to see there is nothing between the clip and no other normal vessel between the clip and between the blades of the clip. The aneurysm complex is also opened, and we see there is no flow, there is absolute hemostasis.